Where do our decision rules for syncope come from? By the end of this video, you should be able to critically appraise 3 journal articles that attempt to validate the San Francisco and Boston syncope rules. You'll be able to compare the methods and results of these 3 studies and to evaluate the appropriateness of applying each rule in different scenarios based on an understanding of how each rule was derived. Let's do a deep dive into the science behind these tools, starting with the San Francisco rule. Recall that the San Francisco rule can be remembered using the word chess, and that having any one of these 5 characteristics, CHF, hematocrit less than 30, abnormal EKG, shortness of breath, or systolic blood pressure less than 90, makes one chess positive. In 2006, a study was published in the Annals of Emergency Medicine validating the San Francisco syncope rule. This study was a prospective single-center trial. The study enrolled any patient who came to the UCSF ED with syncope or near syncope from July 2002 to August 2004, and they excluded patients with trauma, intoxication with alcohol or other substances, and patients with known seizure. Doctors evaluating these syncope patients in the ED were instructed to enter into the computer the chess characteristics of each patient, so it was known which patients were chess positive, but then to admit based on their typical practice, so chess positive patients did not coincide perfectly with actual admissions. Thus, for each patient, the authors had information about whether the patient would have been admitted based solely on the San Francisco rules, in other words, chess positive, and could compare that intervention to admissions based on physicians' typical practice. The outcome being measured was referred to as any serious outcome, and the study designers came up with a whole host of outcomes that would be considered too serious to miss. In other words, the outcomes that you would definitely want to be associated with chess positive patients. These outcomes included death, cardiac events such as MI, arrhythmia, and PE, neurological events such as stroke and subarachnoid hemorrhage, anemia or hemorrhage requiring transfusion, having a procedure to treat something likely to have caused the syncope, and finally, a subsequent hospitalization or readmission within those 30 days for the same or similar symptom. The results of this study were pretty impressive. The chess criteria were found to be 98% sensitive for predicting those serious outcomes. This means that when you look at all of the patients who had serious outcomes, whether it be death or a cardiac event or something else from the list, those patients were chess positive almost all of the time. The specificity of the rule was 56%, so chess positive patients often didn't have serious outcomes, but the high sensitivity suggested practitioners wouldn't miss many serious outcomes if they applied the chess rules. The researchers also calculated that if the San Francisco rule had been used on all patients presenting to the ED with syncope, the admission rate would have been 7% less. And if the rule was used only on those patients who were admitted based on the treating physician's typical practice, admissions would have been decreased by a quarter. And that is ultimately how the authors recommended applying their decision tool. First, use clinical judgment to decide whom to admit, but then filter those potential admissions using the chess criteria. That all sounds great, doesn't it? Well, it turns out that when the good researchers in San Francisco tested their own rule out in San Francisco, it did look like a great rule. The problems only started when people outside of San Francisco started testing the rule on their own patients. There was a 2008 study, also published in the Annals of Emergency Medicine, that came to a very different conclusion from that in the 2006 paper. The study tried to replicate the original almost exactly. It was another prospective, single-center, observational study. They looked at patients presenting to their New York City ED with syncope or near syncope between January of 2005 and December of 2006. They used the same exclusion criteria, and they were examining the same intervention and control. The outcomes were the same as those defined by the original study, including death, cardiac events, neuro events, etc. And the only difference was that instead of waiting a whole 30 days, they did all of their follow-up in 7 days. But the results were not the same. This analysis showed a sensitivity of just 74%, which means that the San Francisco rules in these patients missed a quarter of the very serious, too serious to miss events. The specificity of the study was 57%. The authors, unwilling at first to accept this result, after all, they were trying to validate the rule, not discredit it, went back and did some further analysis. See, that 74% came from them excluding patients who had missing data, patients who for some reason didn't have all of their chest criteria entered into the computer. So they said, what if we assume that all of those patients who had missing chest data actually had data that matched up with their final result? So if they had a serious outcome, they would automatically be chest positive. When they recalculated using those assumptions, the sensitivity was just 75%. And the New York City authors concluded that the San Francisco rule just didn't hold up in their population. So how do we explain the different findings in these two studies? It could be as simple as understanding the differences in the two populations that were used to test the rule. The rule was initially derived and tested on the San Francisco population. While the New York City population was largely minorities, many of whom had poor access to care, and only included adults, the San Francisco cohort was largely white, seemed to have good access to care and follow-up, and included a pediatric population. It's not difficult to imagine that there might be differences between these two cohorts in the two different studies that might affect the generalizability of the San Francisco rule. Seeking a better rule led us to the Boston Syncope criteria. Recall that there are 8 criteria, which spell out bad heart. B is for brain event, A is for abnormal vital signs, D is for depletion of volume, H is for heart attack, E is for electrical conduction abnormality, A is for aortic, pulmonic, tricuspid, or mitral disease, R is for a relative with sudden death, and T is for terrible ticker. These criteria were developed by combining the San Francisco criteria with expert opinion. The study itself was pretty similar to the San Francisco study. It was published in a 2007 Journal of Emergency Medicine. The study was again a prospective, single-center, observational trial, and the population was patients 18 and older presenting to this Boston ED with syncope between September of 2003 and April of 2004. The authors chose to exclude coma, head trauma, near syncope, persistent altered consciousness, hypoglycemia, intoxication, and seizure. The intervention was patient admission based on being positive for at least one of the Boston criteria, and the control was admission based on typical practice, just like in the previous studies we have discussed. For their outcome measure, the authors used critical intervention or adverse outcome within 30 days. Critical interventions included placement of pacemaker or implantable cardiac device, percutaneous coronary intervention, surgery, blood transfusion, CPR, change in antidysrhythmia medication, endoscopy with intervention, or correction of carotid stenosis. Adverse outcomes included PE, stroke, sepsis, dysrhythmia, intracranial bleed, hemorrhage, MI, cardiac arrest, serious sequelae of syncope like rhabdo or fracture, and death. The results of this study were, again, pretty promising. The sensitivity of the Boston criteria was 97%, the specificity was 62%, and the negative predictive value was 99%. These values are in line with those cited in the original San Francisco criteria validation study. So it's not surprising that these authors suggested that the use of the Boston criteria might effectively and safely reduce ED admissions for syncope. This decision rule certainly has an advantage in that it wasn't exactly derived on the same population it was tested on. However, testing in varied populations at different centers will be necessary to validate the tool, as we have learned from San Francisco.